Hi, everyone. I'm Cindy Gavin, CEO and co founder of Let's Win Pancreatic Cancer. On today's podcast, we're going to learn more about screening for pancreatic cancer. And now over to you, Alisyn.
Hi, everyone, and welcome to our fourth episode of PancChat. I'm Alisyn Camerota. In our last episode, we learned about the risk factors that can increase a person's chance of getting pancreatic cancer. So today, we take a closer look at what people in that higher risk group can do to catch the cancer earlier. My husband, as some of you may know, died of pancreatic cancer less than a year ago. So this is a very important topic to my family and me, as it is to our next guests. So let me bring in Dr. Anirban Maitra. He's an internationally recognized pathologist in gastrointestinal cancer research and translational oncology. He'll be joining NYU Langone this September from MD Anderson. He will be the new director of the GI Cancer Center and associate director of translational research at Perlmutter Cancer Center. We also have Dr. Michael Goggins. He's a professor of pathology, medicine, and oncology at Johns Hopkins University. He practices gastroenterology at Johns Hopkins Hospital and is the director of the Pancreatic Cancer Early Detection Research Lab at Johns Hopkins. Both Dr. Maitra and Dr. Goggins have been recipients of research grants from PanCAN. It is wonderful to be able to call upon both of you again. Thanks for being here.
Thank you for having us.
Thank you, Alisyn.
Okay, so welcome back. Dr. Goggins, let me start with you. Is there something that someone at higher risk, who knows they're at higher risk for developing pancreatic cancer, even if it's a smaller risk, what can they do proactively?
Well, the big question is, are they eligible to get pancreatic surveillance, which currently is imaging the pancreas? So that's seeing an expert, seeing a clinician who does these scans, preferably as part of a study. That's it's getting MRI scans, endoscopic ultrasounds, not just once in a while, but a very regular schedule, typically an annual schedule for people at familial risk or genetic increased risk. So the main thing is screening, and we can of course talk further about that. In other words, or surveillance. We'd love to be able to add in blood tests. There are studies that are being done both for pancreatic cancer early detection with blood testing, for multi-cancer detection. Those are still under investigation. For pancreatic cancer, the goal is diagnosing somebody when their cancer is early. Stage 1 is very important compared to higher stage. In particular, some cancers, the difference in survival, is certainly there, but it's pretty dramatic for pancreatic cancer. So, seeing small cancers, which we can do with these MRIs and endoscopic ultrasounds. So we offer that to people who we judge to be a sufficient risk. Maybe one day we'll be, we'll have all these other cancer prevention treatments and lifestyle modifications that, reduce cancer risk. But for now, it's about, are you eligible for screening?
Dr. Maitra, what do you see that people can do proactively?
I think one of the things that Mike mentioned in passing, is being modest, but is very important, is to make sure that you go to the right people, because some of the tests that are used for surveillance require a fair degree of expertise, so you don't do false positives. It's one of the worst things you can do is to tell someone, look, you may have pancreas cancer, and the anxiety and the tests that follow with that when they actually don't, it can be quite daunting. And so again, it's very important, as Mike said, to do this in a high volume center with someone who has expertise in these surveillance programs, because the pancreas is it's not like a mole on the skin. It's something deep inside your belly. And these imaging studies have a lot of different things that they can pick up that has nothing to do with pancreas cancer. So really important to make sure that if you are going to take this route, you talk to someone who's an expert. And again, I emphasize, I come back to the lifestyle risk factors that, again, there's no one single thing you can point to, but together they all add up, like the smoking and the alcohol and watching your weight and exercising. All of these are good things that, again, There is nothing prescriptive that a physician can do, but this is something that you can hopefully do on your own. And certainly if there's a family history, smoking is something that I would strongly dissuade people from doing, from taking on, simply because, again, that there is an additive effect of having a genetic risk and then the environmental risk that comes from tobacco smoke.
Dr. Goggins, you just mentioned preferably people could do this on a study. I assume that you say that because insurance won't cover this for most people. Am I right?
Well, yeah, insurance covers it variably. We would like more uniform coverage. Actually, insurance mostly covers, when I say study, I meant in the context of we're still at the stage where we're learning, even though we have learned a lot and we've shown that you can achieve long-term survival. People looks like they're cured of the disease, living more than 10 years after pancreatic cancer diagnosis, especially if they've had an early stage disease, stage 1. But being part of a study so we can follow people over many years. Our program has been in existence for over 25 years. That's the way we learn. We have people who want to, help the community of families and people who've been affected by this disease. So they're very generous in being involved with studies. But insurance coverage is good, but it's variable. Sometimes you won't get coverage for an MRI unless they see an abnormality in your pancreas. Some centers, some places you won't get coverage for your endoscopic ultrasound. It's very variable across the country, and we want to get more uniform insurance coverage for people who we believe deserve it.
Yeah, I mean, they won't cover it unless you see an abnormality on an MRI, and you don't see an abnormality on an MRI unless they cover it and you get an MRI. It's this catch-22,
That's right.
But because you're involved in this, Dr. Goggins, how do doctors like you determine who should be screened regularly and who's eligible for a study?
Yes, and again, because it's not a once-off, right? Getting a test, maybe a simple blood test every 10 years, it's a bit of a weighty question. So we're trying to estimate what we think your lifetime risk is and when that risk starts to manifest in a significant way. So typically it's patients, age 50 or older who have more than one first-degree relative, a parent or a sibling with pancreatic cancer. And I say more, in other words, meaning they have, two siblings. They have a parent and a sibling, or a parent and a grandparent, blood relatives, same side of the family, or even more sometimes. And so they meet these family criteria. When you have more than one first relative pancreatic cancer, your risk is going up again. You start to go from 5% lifetime risk to closer to 10% lifetime risk. So we're actually trying to estimate risk as best we can with your family history. Maybe there's abnormalities that have been seen in your pancreas, and that'll determine whether we should keep doing your surveillance. And again, the gene testing. The gene testing will tell us if your tests, if you're from a family who has a BRCA gene mutation and there was a pancreatic cancer, and your immediate blood relative had that, and you don't have a BRCA gene mutation, well, your risk is going to be lower. So we're weighing the family history and the genetics. Sometimes we want to see both. We want to see your BRCA gene mutation carrier, let's say a BRCA2, and you have a family history of the disease, or even if you don't have a family history of disease. For some of the gene abnormalities that we see, their risk doesn't convey a lot of risk. And so we want to see both the genetic abnormality and the family history. We're just trying to be selective because burdening people, first do no harm with trying to do early detection. We're inviting people to participate, but we don't want to invite people to participate in surveillance if their risk is judged to be only mildly elevated.
Dr. Maitra, some tests can be quite invasive, as you well know. I mean, there's endoscopies,
Yes.
And then there's relatively easy tests like blood tests. So with pancreatic cancer, can't we just start with a blood test?
So that's a great question, Alisyn. And I think one of the things we have to keep in mind is, first and foremost, there is no easy blood test for pancreas cancer for screening purposes. There is one test that is used for diagnosis, that is not bad for diagnosis. It's called CA19-9. And when you really suspect someone has pancreas cancer, your physician or oncologist or surgeon will order that test. And then after you're diagnosed, you can use it to monitor treatment responses or if the disease is coming back. But in somebody who is completely asymptomatic and where you are not really sure if the person has pancreas cancer, CA19-9 is not the best test. I mean, it's the best we've got. So I think there's a lot of research going on right now, and I do want to talk a little bit about where we are going, not just what we have now. And there is tremendous amounts of research going on right now to develop a blood test that will allow us to enrich for individuals who may be at higher risk for pancreas cancer, and so that you can do some of these more invasive tests like endoscopic ultrasound or CT scans, which do give a certain dose of radiation. So you don't want to use them, unless there is a warranted need for it. So you want to have a blood test that really, think of it like an inverted funnel. So you start with the top, which is the general population, and every step you are coming closer and closer to the spout of that funnel. And the closer you are to the spout of that funnel, one, the more you can justify using these tests, and two, the chances that you'll end up with something false positive becomes less, because now you're looking at this really high risk population that's enriched for a greater risk of pancreas cancer. So just to give you an example, I talked about new onset diabetes as a manifestation of a silent pancreas cancer. Now, many pancreas cancers present with new onset diabetes, but the reverse is not true. New onset diabetes in the average population is still new onset diabetes unless proven otherwise. So I think I want to make sure that we really convey the two sides of the coin here. So in somebody with new onset diabetes, you need these additional supporting evidence, which could be weight loss, not responding to diabetes medication. And this is where a blood test would be really helpful, because then it would get you closer to that spout of that inverted funnel and say, this is someone who doesn't just have new onset diabetes, but has these other things that bring us now to a higher enrichment level that would justify the radiation dose of a CT scan or the invasion of an endoscopic process.
And Dr. Maitra, just one follow-up, because that blood test, it's called CA19, right?
CA19-9.
Okay,
There's
CA19
19-9, yes.
Got it, 19-9. Since that is so instrumental during the course of treatment, why not start there? I mean, if you have a high CA19-9, doesn't that signal send off an alarm bell? And
yeah,
why not start there?
So you can certainly do that test, and the two issues with it. One is it positive in someone who has what we would call a small tumor that is not yet manifest with the usual symptoms of pancreas cancer, like jaundice and weight loss. So, and the term for that is sensitivity. Is it catching everyone that has the cancer and not missing anyone? The sensitivity in low stage disease, and Mike can correct me because he really is the expert on biomarkers, the sensitivity in low stage disease is not very high. It can be as low as 25 to 50%, or even lower, depending on what stage we're talking about. So the sensitivity is not very high. The other concern is specificity. That term is used to say when how many individuals is it picking up that actually don't have pancreas cancer. So if something has a 99% specificity, it means that it's really good test, but it's still picking up some false positives. And for a disease like pancreas cancer, where the population prevalence of the disease is still, thank heavens, not very high, unlike lung cancer, for example, the positive predictive value of a test, which means when a test is positive, is it truly positive, will be very low for the general population with pancreas cancer. And this is why, again, we come back to the key terminology I used before, which is enrichment. You have to enrich the population that you are testing in order to make sure you're not getting a lot of false positives and sending people into CT scans who don't merit getting CT scans done. So this is why, yes, you can do the CA19-9, but it is a little bit, if 3 of us got CA19-9s done, it would be fraught with a lot of danger, because one, it might miss a small cancer, but worse, it might turn out to be quote unquote false positive, and then you're sent down this path of investigations and worry where it's not warranted.
Do you agree,
Yeah.
Dr. Goggins?
Well, it's an important question. So it's a blood test that's been studied for a long time. We have been studying it, ways to improve CA19-9 interpretation. And so one of the reasons why it has been flawed as a screening test is because there's so much variation in how much people normally produce. And so we have a gene test study. In other words, in this case, just a CA19-9 gene test study. So that, you may make very little CA19-9 normally, Anirban may make an intermediate level, and I may make a high level. And so when you draw that first time without knowing where a person is, you're going to see a lot of the false positives. And that really creates a lot of trouble because people get worried about a test. Maybe you start looking about doing additional testing. So we want to balance those trade-offs. We want to minimize the number of false positives. When we do a gene test for CA19-9, we get a much better idea of what is a true, true positive, true negative, false positive. So it really improves the performance of the test. And what we're doing as part of a clinical trial is following patients who are getting their pancreatic surveillance with their scans and their endoscopies and looking at CA19-9 with this gene test as well. So you get a one-time gene test, and then you get to use CA19-9 in a much more effective way, in a way that could be part of a surveillance program clinically. We're doing it as part of a study, but we're hopeful that that can be part of, not necessarily sufficient on its own, but part of a screening program, with imaging or maybe with other blood tests in the future.
So for people who are at that higher risk, they have one or two close relatives or they have the BRCA gene, how often should they be screened and what are we talking about?
Yeah, so typically, it's not like colonoscopy where you can go every 10 years often. It's more like mammography, right? The pancreas is a small gland. You're looking for something solid, and you want to catch it early. So like mammography, getting it every year, it's typically every year, even occasionally more frequently. We're often intervening with the blood tests in between every year, but often it's every year. Some patients, maybe it's a little bit less frequently. Let's say those who have the sporadic cysts and they only have a small cyst. But generally speaking, it's a scan every year. Maybe, that could be an MRI one year and an endoscopic ultrasound the following year, and so on.
And Dr. Maitra, any
Yeah, I
thoughts?
was just going to say, I think one of the things that hopefully we've been able to convey through all of these discussions is, yes, surveillance is possible for pancreas cancer, but it's a very nuanced and complex discussion. It's not a one size fits all that you can just go to, your physician down the street and say, all right, let's get a CT scan done or let's get a CA19-9 done. That is fraught with a lot of danger. So I hope the one take home message that we want to convey is that if you think you are at risk, talk to someone who does this for a living at a high volume center, because he or she will know exactly what to do personalized to your risk. That's really an important point. Your family's risk or your children's risk may be different from my children's risk. And I really think that discussion is one that needs to be had. There is no one size fits all.
I do want to talk about children's risk because now that I'm, in this horribly tragic club, this is what other parents do talk to me about. What should we do about our kids? And all of our kids are relatively young, they're teenagers or they're in their 20s. So for somebody who has had a parent die of pancreatic cancer, at what age should they start to worry about this or just be conscious of it, I guess, and start to be screened? Dr. Goggins first.
Yeah, so one of the things to understand is, often we nowadays we get a gene test, for people with pancreatic cancer to understand how it may affect their family. It may even have treatment implications. So, did your affected relative have a BRCA gene, have an ATM gene, have some other cancer susceptibility gene? Because of course, if they have to think about the cancer risks related to that gene. most of the time, if you take 100 people who have pancreatic cancer, perhaps 1 in 10 of them will have a significant gene test result, which would have implications for the family. Maybe we'll learn more about that, but in the future. But at the moment, it's at that 1 in 10. And I mention that because sometimes that can start at a young age. Maybe you have, a woman has to get breast cancer screening in their 30s, and other kinds of screening in a small percentage of people. If that's negative, again, we're looking at the young onset pancreatic cancer. Is there someone in the family who has had a cancer very young? And we're thinking back, maybe we should start surveillance 10 years younger than the youngest member in that family. In general, we're starting surveillance for people, at age 50. Maybe some centers would consider 45. It depends on the gene test abnormality in the family history. And so young people, it's too young for pancreatic cancer, really. It's the trade-offs of maybe I should get screened early. The problem there is that maybe we see some minor thing in the pancreas that means, very little in terms of risk. So, thankfully the risks at any one point in time is super low when you're young, well less than 1 in 1,000. Even when you have a family history, the chances can be really super low. So, we don't want to over worry people and getting them, involved in the healthcare system. Maybe they start doing something too early, and then after 10 years, they're sick and tired of doing this, and they stop doing it when they really should be getting started.
Yeah, Dr. Maitra.
It's just do no harm aspect of screening.
I want to bring something in the discussion, Alisyn, if that's okay, because I think on this particular subject, the horse is out of the barn in the United States, which is these multi-cancer early detection tests, and a lot of people now paying for them out of pocket, $900 or $1,000 to get a blood test done to look for lots of cancers. And many companies are offering them. If you go to your PCP, they can order it, or you can order it online. And now the other thing on the other end is whole body MRI scans are being offered as a service in many cities. Houston, where I am, is one of the cities where you can sign up online and you pay a certain amount of money and get a whole body MRI. And people are doing it. That's why I said horses are the barn on this. And things will show up. A signal will show up on a blood test, or something will show up, just as Mike said, on MRI. What do you do at that point if you're worried? One is, that's one point where you really need to make sure, as the next step, you go to someone like Mike or other experts, again, at a high volume center, and say, what does this mean? Because it's very easy for this to go awry. And the other thing to remember is that, at least today, and these tests are getting better, these blood tests, at least today, many of the true low stage disease, that stage when you really want to catch pancreas cancer early because of the potential for cure, these tests are often negative. They're not very good at picking it up. And that's just the reality of where we are with the technology and the biology of the disease. So it can be almost a sense of false reassurance. So my only advice is, one is think carefully, because you can do it. You can pay the money and you can get a whole body MRI done in any of the big cities, or you can get these blood tests done. But it doesn't necessarily mean a negative is a negative. It's a little bit of reassurance. And two, if something does get picked up, it doesn't mean it's positive either. That's when you need to really go and talk to an expert. What does this mean? So I wanted to just bring this up because it's out there and people are doing it by the millions now. And we're going to be dealing with an epidemic of signal on these tests. And what do we do with that?
Yeah, I really appreciate you saying that. I understand exactly what you're saying. Sometimes ignorance is bliss, if it is in fact nothing to worry about.
I would just add, because it's something that would need to be done regularly. Getting it once is fine, but if you have to do it every year, there's financial cost, is all the worry. And having said that, to Anirban's point about these blood tests, we enjoy the search. Things are improving in terms of the science and the research. So, we can expect that the situation will improve. I do think that there will be better blood tests for pancreatic cancer, early detection, that are worthwhile, that will, advocate for in the coming years, to build upon what we've been doing. Just at the moment, we're not quite there in being able to, have these tests do what we'd like them to do.
Yeah, I understand. And so on that note, finally, and you alluded to this earlier, Dr. Maitra, what does the future look like? You wanted to talk about where we're going.
Yeah. So I cannot have a conversation in 2025 without using two words: artificial intelligence. And I do want to use that. AI is going to be a huge part of where we are in terms of where we already are and where we are going in terms of the diagnostic of workup of pancreas cancer and early detection. I think, and Mike, I know he's already doing this kind of work at Hopkins, and so are we here at MD Anderson. We are incorporating AI at various steps. Let's talk about who is at risk. We talked about, hereditary risk because you carry a mutation or these cystic lesions in the pancreas. But in the vast majority, such as the real unfortunate case with your husband, there's no one thing you can point to and say, this is what was causing. But then can we go back and mine years of medical records that all of us have? I mean, every time I go to my PCP and get an annual checkup done, he or she enters 100 pieces of data on a computer. Over 15 years, no one's looking at those patterns to see, is there something in there that might point to a higher risk of pancreas cancer? This is where AI can really help in selecting those who are at a higher than average risk and saying, this is someone who should go to Dr. Goggins and potentially consider a surveillance program. Even though there's no mutation, there's no cystic lesion, out of the thousands and thousands of pieces of data, there is a signal there that points to a higher risk. That's where AI can be really helpful. The other thing is, now that you go to someone like Dr. Goggins and he's doing endoscopic ultrasound, can AI help you pick those out of those little shadows in the pancreas, the one that really matters? And that's where AI can really help with improving the radiology that we do on patients. And then finally, AI is already being used in terms of these blood tests to, again, pick signals out of thousands and millions of data points. So I think AI is going to be a big part of the entire sort of, passage of workup for patients for early detection. And I think we're going to see a lot of work being done in that space.
Dr. Goggins, anything to add as you're on the vanguard of this?
Oh, well, yeah, no, I totally agree with Anirban. It's fun being able to use these tools, but we have to learn how to use them. Yeah. I would add something simple, which is that a lot of these studies, the blood test studies and using AI, so, it's about, studying a group of people at risk, right? What we really need to do, and I think we'll get better at doing this, is understanding the personalized aspect of it, the individual, understanding how some blood test changes over time in the individual. So individualizing what we do much more will create much more diagnostic power, improve our ability to do things. So really having a more personal approach where we're able to, utilize the information that we have to give more powerful interpretation and guidance is also part of the future, personalization.
Well, Dr. Goggins, Dr. Maitra, thank you both so much for having this conversation and for your expertise and for all of the work that you're doing. It's great to talk to you. I really appreciate it.
Thank you for having me.
Thank you so much, Alisyn.
And thanks to all of our listeners for tuning in. I'll see you next time.
Thank you for joining us for the PancChat podcast on screening for pancreatic cancer. I'm Julie Fleshman, President and CEO of the Pancreatic Cancer Action Network. We encourage listeners to learn more about the resources available for patients and caregivers through Let's Win and PanCan's websites. Go to pancan.org and letswinpc.org. Be sure to tune in next month when PancChat podcast will focus on the different types of treatments for pancreatic cancer and where clinical trials fit in.